So welcome to the Education Grand Round. Before we start, I'd like to see and acknowledge the people who are connected with us online. Dr. Tabassum, are you there? Dr. Kabir?
Yes, we can hear you loud and clear.
Okay. Dr. Saab?
Yes, I can hear you.
And Dr. Athar?
Yes, sir.
Okay.
I can hear you.
Okay, we have people from ISRA University, Hyderabad, and Islamabad Medical and Dental College, and High Tech Institute for Medical Sciences, Taxila. So with that, I'd like to introduce our presenter today. I know Charles, because we're working in the SciMech. Professor Charles has been a nurse for 40 years and has witnessed much innovation in healthcare, and for the past 28 years in healthcare education. Pioneering work in simulation and PBL in the 1990s, he got his PhD in 2002 and changed the direction of his career so that it moved more towards innovative curricular design and interprofessional learning, and facilitated through technology and simulation. He has experienced the educational systems of the Middle East and the Gulf. His most enduring achievement has been with the Royal College of Surgeons in Ireland, where he worked for 5 years and was awarded an honorary fellowship. As you know, he has recently joined AQU as the Director for the Center of Innovation in Medical Education. And with that, I'd like to hand it over to you, Dr. Charles.
Well, thank you very much for the introduction, and thank you for the invitation to be here. I see we have a very select audience. We could sit around one table, but I think I'll go through with my presentation. I think you'll maybe enjoy the sequential approach that I have taken to this subject. And then afterwards, we will look at some video and have discussion. I meant to put up a disclaimer. I would like to put up a name as well. Sessions designed to challenge, persuade, coerce, cajole, encourage, support, and facilitate the uptake of simulation and technology in your educational practices. Now, to an extent, I'm preaching to the converted. And I think most of you will agree that I've worked in the centre that it offers happiness and satisfaction for yourself and your students. There's no reason why education can't be entertaining, challenging, fun, and stimulating for all involved, and simulation offers that. There is a disclaimer as well, and you can see it there in front of you. The overview, I've done this kind of presentation before, and I try to keep it brief, so I'll stick to about 10 issues, and then look at some pictures and video, and then we'll have discussion. I think it's worth reflecting on why we have simulation in the first place and why there's been this massive investment, not just in AKU, but throughout the world. And it stems from some concerns about the existing systems and also the potential benefits promised in simulation. First of all, clinical competence of graduates can be quality assured through simulation, whereas, and to quote the words of Rowntree, who did his famous book on education in the 1970s, practice areas are swamplands for learners. They get bogged down. It's just by chance who they have to supervise them, what kind of experience they have, whether it's positive or negative. Some graduates have a tough time. Other graduates seem to sail through the program unchallenged. And it's a matter of luck. So if you introduce simulation as a method of teaching and assessing, then you can introduce standards and rigorously impose them across the curriculum. Especially in this part of the world, we have access barriers to patients for students, and based on gender and culture. For example, pelvic examination, male students and female patients, taboo, as is breast examination. So how do you teach these skills that are mandatory in the curriculum? And this is where we need to turn to imaginative approaches. We can use simulated patients if we get express consent by those involved. And we can use mannequins. And mannequins are becoming much more sophisticated and can really inform these kinds of intimate examinations. Complex care environments can be controlled, and you can think about intensive care, busy medical surgical wards, ICU. So we can actually control what happens in these and introduce elements of chaos as and when required when we want to challenge students. These complex care environments are great for learning, but they can actually be very anxiety invoking in students and not an ideal learning environment from their point of view. Specialist placements and environments can be created. Now, it's maybe not imaginable here that in some parts of the world there are a shortage of children, and child placements are very thin in the ground, particularly if you look at the UK, where there's been a declining birth rate and so on, and there's more of a move to caring for children in the community. So how do you provide experiences for all students? So you can create childcare environments, for example. Maybe in this part of the world we need to create a care of the elderly environments. I'm not sure, but it depends on the demographics. Sick people are treated ethically. In simulation, there is no patient to be practiced upon. Competence can be gained in low incidence, high stakes situations, and we know this from all the work that's been done on CPR, BLS and ACLS, and PALS and all the rest of it. These courses have been proven to save lives and give people competence, even in situations that happen infrequently. Students learn in psychological safety. They can make mistakes, and they don't need to worry about harming people. And errors, last point, errors are an important source of learning, and in simulation they can be exposed and utilised, whereas in real practice they're covered up and they're not talked about. So the 10 issues, I'm going to start with how do you simulate reality. First of all, real environments are important. It's established good practice, and there's been some evidence to show that it enhances transfer of learning. If you learn in a skill in a particular environment that's very similar to the environment in which you're meant to practice, then it's easy to take that skill with you and practice in the real environment. So having that similarity between simulation and reality closes the gap, and transfer of learning can occur. It also helps suspend disbelief. You have to suspend disbelief at some point in simulation. Is this plastic mannequin a person? Is this simulated patient real? Is this theatre environment a theatre environment? So having to suspend disbelief on absolutely everything in a simulation makes it a bit unrealistic for the students. They don't get into role. But if you can simulate environments, simulate procedures, uniforms, everything, then the last bit of it, imagining that the mannequin is their patient, it then becomes achievable. Mentioned uniforms, vitally important. Students get into their role, and faculty in uniform enhance fidelity. So the centre that we have has the facility for students to be in uniform. It's a matter of people being organised, coming early enough, getting changed, getting into their role, and for faculty to develop teaching and learning routines that require students to be in uniform. And they're not standing back looking, observing. They actually have to get involved, touching and manipulating. So, let's see, part and parcel of the same thing. Another way we can enhance the reality of a simulation is through high fidelity simulators. And we have three-dimensional virtual reality simulators with haptic feedback. You actually feel as if you're performing the procedure. This is mainly for postgraduate medicine that we use this type of equipment. But it is very well received, and our postgraduate programs are making increasing use of this equipment that we have here. So the second point is that students, when they're undertaking simulation, require to be adequately briefed initially. Now, there are various ways of doing this, and sometimes it can be like 2 minutes in the corridor. Other times you want to make express efforts in getting the students to think, what are we building this experience on? What are the theoretical concepts that have been included in your program? And make it much more of a session. Now, that need not happen each time, but sometimes it's important that through principles of scaffolding that you actually remind students of what they've learned already and how this is going to enhance, so that when it comes to remembering and learning from the experience, they've got something to build upon. Facilitation, it's as in problem-based learning, the best facilitator is a guide at the side and not someone who's the giver of information, the giver of direction. They facilitate. And during a proper simulation, then the facilitation comes by way of constructing the scenario and including all the elements of that scenario that help the learner to be guided into what is required to be learned. Now, it sounds complicated, but it's actually quite simple. When we see the video at the end, you'll see how it comes together. That you provide the environment, there might be a nurse in the environment, there might be other practitioners in the environment. They're there not as learners, but as someone performing a role. The learner goes in and performs their role in the context of that environment. That's how learning is facilitated in the setting up of the scenario. After simulation, I have a process of debriefing which is skilled. Most nurses have been doing briefing, debriefing, reflection and practice for many years. Medics who've been involved in teaching using problem-based learning have got the skills for this. These skills are transferable, so debriefing, although it is fairly new as a term to describe this process, it's very similar to becoming a reflective practitioner. Thinking about your strengths, thinking about your weaknesses, being prompted to explore these in the company of an expert. So that's the way it happens, and again we'll see some of that in the video. There are some question marks to be asked over this. What is the best method? Is it dose dependent? Is 10 minutes as good as 20 minutes, as good as 40 minutes? I think there's a little bit more research needs to be done on that to make it a bit more efficient and acceptable within a curriculum that's busy with students and other activities. And for debriefing, having video available is very useful. It facilitates the process of video stimulated recall, where you observe yourself in practice, and watching yourself practicing allows you to go back over your thinking process at that time and then look at strengths and weaknesses in that. So it's very important. Yeah, there's an old saying, don't share the stage with children and animals. I would put technology onto that list as well. Technologies for simulation, these can be quite complex, quite expensive. Some of them are absolutely essential, others are mandatory and would be in a wish list. We have clinical and learning technologies. Everything that you could see possibly happening in a hospital can be included in a simulation. So you'd want all of that technology, the clinical technology. So here we have an ultrasound. You could have anything, ventilators, everything. So there is a requirement in some scenarios to have that extensive technology. Many scenarios don't need any technology actually. You can simulate interpersonal relationships, interprofessional relationships. and look at strengths and weaknesses through the video stimulated recall and so on. So they're not absolutely essential for everything, but again, to enhance the reality of a situation and to acquire competence in the utilization of some of this technology, it's useful to have. When you have technology, you always need to have information technologists, IT guys, and biomedical engineering. So we are pretty strong in that in the centre, and it's great to have that level of support around. I think it's mandatory these days. Mannequins. Some point, or sometimes I think I'd like to take mannequins out of the equation, because it implies that you always need to kind of consider using mannequins, and that's not the case. Some of the best simulated scenarios exist without mannequins, but in some situations mannequins are necessary. For example, if you're using a nasogastric intubation or endotracheal intubation as part of the scenario, then you don't want a simulated patient to undergo something invasive like that. So a mannequin, if it does the job, it's actually better than a simulated patient. But if it's communication skills that are being taught, then you don't want to be spending too long talking to a mannequin, whereas a person in the bed would be much better. So there are lots of different types of mannequins, some of them designed for nursing, and they've got lots of orifices that you can put things in and drain things out of, and you can simulate bed bathing and position changing and things like that with these kinds of mannequins. Some of them are a bit more expensive, a bit more interactive, and you can communicate vaguely with them. It depends on who's on the other end of the connection, speaking through the mannequin, what kind of response you'll get. Other mannequins have got very sophisticated physiological simulation built in, so that if you give a drug, you'll see the response to that drug in the parameters that are being measured on the mannequin. So give one drug, the heart rate might go up, the blood pressure might come down. Give another drug, the reverse might happen. If you make a mannequin bleed, their heart rate will go up, their blood pressure will come down. These kinds of physiological responses can be inbuilt and programmed. There is a whole issue of cost. Many of these are into the hundreds of thousands, and are they value for money? Then it really depends on how well they're utilised. If you utilise them a lot, then of course you can argue that you're getting good value from them. But if they're lying there 4 or 5 days in the week without being used, then you would argue, when this is obsolete, are we going to replace it? We need to think carefully about that. And they're not the answer to everything. Simulated patients, and I just discovered recently that, I knew we had simulated patients, but I just discovered recently that we've got a very well managed pool of simulated patients by DED. And it's something I've got an interest in trying to build on. So I will work with DED in building this pool and advertising for more simulated patients, because I think within all our programs we can use more of them, and they're excellent to have. They need to be well maintained though, and I think we will, as I agreed with DED, we will have an event to talk to our simulated patients, bring them up to date with what's happening in the centre, give them some tea and cake, make them feel as if they're wanted and valuable, and we'll look to ways of increasing this pool. It's important that you look after simulated patients. There are some ethical issues in relation to all of this. Some patients have been shown through studies to suffer psychologically through repeatedly being asked to play the same sick patient, so that's got to be observed for. Curriculum integration. This is an absolute requirement. At the moment, we're chipping away at the edges of the old curricula and trying to adjust what people are teaching to a new situation. And that's never satisfactory. You've got to actually have tailor-made curricula that allow simulation to be used for its maximum benefit. So we're working on that at the moment. Another concept that's always talked about as being beneficial is interprofessional learning. But there's major difficulties between medicine and nursing in bringing people together in classroom sessions. Sessions that share the same learning outcomes at the same level for groups of students in nursing and medicine is quite a difficult task. So unless curricula are designed with that intention in mind, it's not going to happen spontaneously. So there needs some conscious effort into the curricula to identify areas where interprofessional learning can occur. And where that's possible, simulation makes it easier to involve doctors and nurses, other professions in a simulated environment, looking at multi-professional learning in practice. With such a massive investment, money, time, expertise, changing curricula, increasing students' expectations of what medical and nursing education is about, we really need to do some research and find out if it's actually delivering its outcome, any outcomes that are worthy. Anything that's included as practice needs to be evidence-based within a simulation. We can actually use simulation to evaluate existing practices as well. Maybe do randomized controlled trials in the simulated area. We can engage with external agencies, and the picture there I have is from Scotland, where we did some work with agencies in media and producing television programs and so on. I'm not sure there's much call for that in Pakistan, but there might be. It's difficult getting access to wards for filming, so we have nice wards there, pristine. We can use them. The simulation industry is always looking for new developments. We should be at a point in time when we've used all the simulation equipment that's out there. We're bang up to date with what we're doing, but we need more. And we can specify what else we need and work with the simulation industry to try and develop these new products. Any university has an obligation to engage with the community, and I think as a big centre within the university we have that obligation as well. There's very useful clinical skills, routines being practiced in simulation that if we share them with the school kids, teaching them how to do basic BLS, first aid, then maybe we could make lives a little bit easier for people. People get better treated before the ambulance comes, and so on. So there's lots of ways we can engage with the community, and we're exploring that at the moment. The last point is, and I mentioned that we have IT and biomed, but it's a team sport simulation. It's not down to 1 or 2 people or 3 or 4 people. It's a whole group. Very mixed skills that are required in order to deliver a useful simulation. So there needs to be an understanding of education and pedagogy. Is student-centered, adult learning. How do we facilitate that through simulation? How do we give students the rightful place as directors of their own learning? Course design, curricula, obviously need to be adjusted, so we need some expertise in that. Teaching, learning and assessment. These skills used in everyday teaching and learning need to be adapted somewhat for simulation, different context, different environment. All sorts of technicians are required. In a big centre like CIME, we have a requirement for managing events, conferences, workshops, simulations. Theatre, we need actors. Medicine, nursing, allied health, obviously we're needing to produce simulations that are valid for students of these disciplines. And hospital health services management, we need to include realistic hospital environments. And when you look at all of this and look at what's required, you'll not get all of this in a small number of individuals, but you can actually begin to blend people together. And there's two distinct groups that you have. There's technicians with increasing specialty in simulation, and then there's educationalists with increasing specialty in education. And there's overlapping. And if you look at what's been happening in centres that have been well established in the West, there is a new professional developed, a simulation specialist. And I've discussed this with HR, and the university is amenable to a proposal being put forward to look at competencies that are required at different levels in each of these specialties, so that we take people out of IT, out of biomedical engineering, and we give them specific roles and responsibilities in clinical simulation specialties as specialists. And the same with educators. So this is a summary, just the 10 points I mentioned. And just a quick note on the direction that we're about to embark on within the centre. We're drawing up some policies and guidelines at the moment: room booking, a uniform policy, student access to allow them at some point without a faculty. There are some occasions where students could use the space for independent study. Also looking at the increased utilisation by existing programmes and kind of pushing people to become more involved in nursing and medicine, undergraduate and postgraduate, within the hospital. And we're looking to revise curricula. We're also looking at a simulation educator programme and work with DED to get some suitable place for this programme. We've identified learning outcomes of this and some kind of structure. We're just about to see where it fits with whether it's DED or Teaching Learning Net, and then get it launched. We have a group of champions, and I've mentioned the expertise that we have in technology within the centre, but we also have associated champions, and they bring the clinical and educational expertise, and they need to be better utilised. We are developing in a small few groups some super users actually, and so we're going to have sort of two kinds of champions: the representative champions who are there because they represent the department, but not really doing very much other than that representative role. And then we have the other champions who are actually pioneering and being super users of simulation. We need to research and publish. We need to have some proposals. We need to look at the conferences and make sure every international conference we've got something going forward from simulation. And we need to create a sustainable culture of innovation and improvement in clinical education. And that can't just happen in isolation in the centre, it needs to involve the schools as well. And that's a big challenge. So I know time might be running short for people, but I have a nice video. I can cut it down 3 or 4 minutes if you want. We have sound. Just to say that the nurse knows about the scenario. There's a group of observers behind the glass that you can't see from the clinical area. And there's a doctor being told a basic amount of information about the scenario and is having to go in to manage that scenario. So I'm just fast forwarding it. It's a little bit lengthy. The participants are radiology residents, and one guy, the guy in black, he's a resident from Accident Emergency. Okay, that's me finished with everything. What's happening next? Are we having a panel discussion?
So for the next part, we're going to have a panel discussion in which we've invited our panelists, Dr. Ahmed Hamid from surgery, Dr. Imaduddin from emergency medicine, Jacqueline Dias from School of Nursing, and Dr. Irfan Jiva. Would you join us from the Department of Surgery? Are there any questions from the audience?
So thank you, Charles, for sharing and highlighting the role of these mannequins and simulated patients for facilitated learning. So as you have shared, in case of hypertension, we can assess the effect of different antihypertensive drugs. So being a pharmacologist, my question is, if we look at non-communicable disorders, particularly the hypertension and diabetes, and in many more disorders, there is a routine of polypharmacy, multiple drug administration to the patients. So is there any way to facilitate these concepts to the students in case of drug-drug interaction by using our mannequins or our resources in CIME?
Okay,
Thank you.
Emad.
It's a nice question. We have conducted a session on conscious sedation, basically, and in that session we basically involves our residents, and for conscious sedation we use multiple drugs. There is not a problem for the children, but in adults, in which they are taking multiple medications. So we basically started with just a small thing, 2 or 3 medications, and then what the mannequin we have, the SIMN 3G, they have all the vitals and most of the stuff we have it. So we basically program it in a way that if the resident gives some medication, the mannequin portray it like this: a hypertension or hypotension, or this is a drop in the saturation, or she may have a tachycardia, and like this. So we may introduce the drug reactions as per the vitals, and you can say the facial flushing or the sweating. This mannequin can sweat also, and this mannequin can also have the problem with his eyes. It may be dilated, it may be constricted. So we may program it as per the medication, and for the drug interaction, it will be the second stage, which is in the end of the process. We can do it.
The thing about simulation is that you can speed up the time process, so you can adjust half-lives and things like that, and you can show much more in a very short period of time in a simulation. Whereas in real patients, it might be spread over a day or two when you're giving drugs and they're interacting with each other. I think some of these complicated drug-drug interactions, unless they're visible on the surface and in behaviour and in signs and symptoms of the patient, it might be better to create computer simulations to show their interactions rather than through mannequins, I would suspect.
Charles, if I can add one thing, your question is very nice. You see, when we teach students about side effects of polypharmacy, they will remember, they will do multiple choice, but when they're by the bedside, that reality changes completely, because they will, they'd read about bradycardia, they'd read about pedal edema, but over there. So a simulated situation would actually let them translate that knowledge, that book knowledge, into clinical scenario, getting all those questions, the sequences right, without hurting anyone. So from that point of view, it'll be very, very nice to simulate that.
Any questions from our people who are connected online? Dr. Kabir, Dr. Saad, Dr. Athar, or Dr. Tabassum?
Yes, this is Dr. Kabir Dharwani from Misra University. My question is about the role.
Are we still connected online?
Yes, can you hear me? This is Dr. Kabir Dharwani from Isra University. Hello.
Ji, please go ahead.
My question to Professor Charles is about the role of simulation at an undergraduate medical education. I mean, do you have any experience of introducing this simulation at the final year students or possibly post-jobbers?
Yeah, well, it can be introduced at various stages. And I think you really need, if you broaden the term simulation, you can think about task training. You can have all the single tasks, the single skills taught in the first and second year, using parts of mannequins, parts of equipment. And then you can start to bring them together. And through, I think there are some good examples of communication skills training that use a simulation. I'm not so sure that a full-blown, like you saw on the screen there, patient simulation it's not used routinely in undergraduate programs because of the logistics involved in managing such complicated scenarios and with such large numbers of students. So I think that would be the only reason why it would be limited, but virtually any situation that you can imagine from a clinical area can be simulated in one way or another. Irfan.
So in our ophthalmology department, we have introduced for all our undergraduates now to have training for fundoscopy, which is to examine the back of the eye in a simulation scenario. And the results have been extremely encouraging. Not only do the students love the whole activity, but from my observation, what I've seen is that their ability to then eventually practice on the patients is far more effective and efficient. And what's even more interesting is that by the end of it, their confidence level is sometimes even better than some of our junior medical officers and residents, and that is phenomenal. So there are skills, I strongly believe, that we can help our students, be it undergraduate or postgraduates, to learn on the simulation model. But then there has to be some guidelines on how to take this further in real life. And that's what we do as well, and I'd like to think that we're doing a good job.
Can I just mention nursing is probably an area where we're doing a bit more development at the moment and in their internship year. Jackie, do you want to say a little bit about that, the plan for that?
Oh, what we've done in the internship is that because we've done a number of things, and we're looking at how to respond to like first responders and other things. So we've looked at the entire internship for the whole year and working closely with the hospital to see what we can bring about in terms of simulation. So these people not only just learn the skill itself, but as well as other things of communication, how to deal with interprofessionals, how to deal with multiple scenarios, as well as how to deal with angry patients as well as angry relatives and things like that. So we are in the process of creating those scenarios, and we add all those components so they learn as much as close as they would be if they were on the in the unit.
Okay. Are there any questions?
This is Dr. Saad from Islamabad Medical and Dental College. My question is for Dr. Charles. Can you hear me?
Yeah, I can hear you.
Yeah, so Dr. Charles, my question is that you have used two terms, simulated and stimulated patients. What is the difference between these two?
Simulated and standardized, you mean?
Yeah.
Well, a simulated patient would be someone who's acting the part of a patient. A standardized patient would be an actual patient who has classical signs, symptoms of a condition. Let's say emphysema or chronic bronchitis. These are quite difficult. You know, if you've got a barrel chest and club fingers and things like that, it's difficult to get a simulated patient to have these features, whereas standardized patients, you can bring them in, they're there, they live for these conditions for a long time, and you can bring them in and use them for your teaching and learning and your assessment processes.
Thank you.
Okay.
So my question is, if we look at our students when they're moving from their basic sciences for year 1 and year 2 to year 3 and move on, so we feel that they usually have been lacking to integrate their basic knowledge into the clinical skills. So do we have any plan of combine scenario development or combined sessions with the basic science facilitators with the inputs of these clinical clinicians, so that they could focus on these basic concepts in terms of appearance of the symptoms, in terms of efficacy of those drugs, or in terms of any complex concept to be administered to the students? So my question is to panel, of course.
Okay, so this is a very interesting question, and let us accept the fact that we are, on the first step. And so even in the morning, we were discussing that whether we start with the postgraduate education, develop a protocol, then trickle it down to my UGME or run parallel sessions. So all of that will come into account. When I trained, we just did theoretical knowledge first, and then we trickled into the clinicals.
Yeah.
These guys are already problem-based, so they're thinking, they're integrating, and I think bringing simulation would be a very interesting thing and easy, because I see simulation. See, where kids become interested in things when they play, when they actually do simulations with toys and stuff. You're not a pilot, but you're believing to be a pilot, and you play. So that keeps their interest. And I think adults are not any different. And simulate, because once I've started simulation, I'm actually enjoying it. And I had the same thing that I enjoyed as a kid. So I think it'll be very easy for us to incorporate this. How we go about doing it, because it's a complex integration. So we'll have to think about it. We've already started the groundwork, but remember that this is very early stage.
Thank you.
I can add, from the nursing perspective, what we did was integrating a lot of things. One of the courses that I run is care of the elderly. And in that, actually, when we created the scenarios, we brought in all the physiological changes of the elderly.
Okay.
So we actually then asked, the students had an opportunity, if either they saw the change in the vision and the hearing and how they would interact with it. So we try to do as much. So we do, intend to bring in, and we have brought in, and we ran this course twice, and we've actually got phenomenal results as well from it. Our course evaluations have gone up, and they felt that, it was a real experience. Everyone does not get an elderly patient during a clinical rotation. So this gave them we showed the wrinkled skin, we showed the impaired hearing, the cognitive sensory deficits in the elderly, and we portrayed all those signs and symptoms in our scenarios.
Okay, thank you. So I would also like to request that if such type of sessions are going to be organized in the future, so kindly invite from the basic sciences faculty could see, so that they could also try to develop such of the scenarios with the students too. Thank you.
We will keep that in mind. Also, to address your question, I'm as a DAD member or representative for year 1 and year 2, and I do know that for each module, you have a certain amount of clinical skills that are identified for specific modules, right? So now the move is, how do you shift this from the lab environment on those clinical skills training to the CIME? So that's probably one way that the clinical skills committee is kind of looking to integrate clinical simulation into the basic health sciences.
Thank you. Okay. Thank you.
Any other questions? Do we have any more questions online?
I just make 2 comments here. It's very interesting because I was observing the interaction over here, and it was all about, I have learned this in the books and how I can now use this onto the patient. Brilliant, absolutely, you're quite right. I remember the first time when something happened, and it's like, oh God, what was that in the book? And I think a lot of us can relate to that, and giving students this exposure and experience that let's start thinking on those lines, I can only imagine can have a positive effect, and why not? As a surgeon, we think little. It's all about skills. So when I'm teaching my students surgical skills, I'm almost starting from a very bare basics. That this is a cataract probe, this is a retina probe, we're going to go in the eye, we're going to take this cataract out. There is not much in terms of preparation that they have done. And it's very interesting because sometimes I feel that I have an upper edge because I'm starting from a clean slate. I'm writing what I have to without any bias or prejudices. My second comment is in the UK, somewhere around 2005, Royal College of Ophthalmologists decided that for new residents, you can only touch the patient if you have attained a certain level of skills. And the best way to demonstrate that would be on a simulation model. So there's a company called IC, and they worked very closely with lots of educators, and they came up with certain modules. And you can only then go on to the patient once you have attained that level. Now, when I became the resident over here, my group was the first group in the UK who actually went through that training. And it was brilliant because by the time I did my first cataract surgery, it was actually my cataract surgery number 101. And I'd like to think that I didn't go through those sweats that perhaps others may have gone through. And this is what, again, we are trying to introduce in our postgraduate program. It's a very positive thing that we have started. Do we make the most of it is a question we need to ask ourselves.
If there are no more questions, either from the audience over here or from the audience that is connected to us online, can we now conclude the session? Thank you, Dr. Charles. It was an enlightening and very good presentation. And of course, thank you for our panelists for your subject expertise in the matter.